Thank you very much, John. I don't have any conflict of interest. I thought that I would actually have a little bit extra time to talk about these criteria, but it seems that I'm actually going to have a little bit less time. That's perfectly fine. It was actually quite a privilege for me to be on the Rome 4 Committee for Functional Esophageal Disorders amongst very eminent colleagues who you can see listed who were co-authors in this gastroenterology paper. And our remit really was to review the literature to see whether there is a opportunity to revise the Rome 3 criteria for the main functional esophageal disorders as previously described as functional chest pain, functional heartburn, Globus, and functional dysphagia. But during that review, a new category has emerged called reflux hypersensitivity. And there was quite a lot of discussion and debate about this, and I will talk you through as to the reason for why this category has now emerged. But just to give you an overview about functional esophageal disorders, by definition, it is the presence of esophageal symptoms such as heartburn, chest pain, dysphagia, and Globus that are not explained by mechanical obstruction, such as a stricture, tumor, eosinophilic esophagitis-related mechanical obstruction, or any major motor disorders. And I emphasize major motor disorders, and as I come through the different sections, you will know why. Because achalasia, gastroesophageal junction outflow obstruction, absent contractility, distal esophageal spasm, jackhammer esophagus, with the advent of high-resolution manometry, these categories are now very well identified and defined, whereas some of the minor esophageal motor disorders have less importance because they are being identified in healthy subjects. So the focus has been on major motor disorders. And of course, exclusion of gastroesophageal reflux disease has also been important. These conditions have to be chronic for at least 3 months and with an onset of at least 6 months before the diagnosis. So that's in general for all of the functional gut disorders. As Jean mentioned, there have been some change in criteria between Rome 3 and Rome 4. And again, I will first cover them in a very general way, and then we will narrow it down to each condition more specifically. Previously in Rome 3, there was a term that histopathology-based motor disorders was used there. But in Rome 4, this is no longer the case because motor disorders are not really diagnosed based on histology, but more on motor patterns. So it's the physiological changes that have been emphasized in Rome 4. Descriptions of spastic and hypercontractile motor phenotypes have expanded the exclusion criteria. So better diagnosis of these distal esophageal spasm and jackhammer esophagus, etc., those phenotypes have become an important part of the exclusion criteria. But minor abnormalities like ineffective esophageal motility and fragmented peristaltic, etc., are not exclusions because, as I mentioned before, they can be seen in asymptomatic control. Emphasis on ruling out mechanical obstruction is quite strong, and like we said, esophageal junction outflow obstruction, and it's recommended that investigations such as endoscopic ultrasound, contrast radiography should be considered if EGJ outflow obstruction pattern is recognized so as to not to miss important diagnosis. And eosinophilic esophagitis on endoscopy or on mucosal biopsy is required in most of the functional GI disorders, which again is in addition to Rome 3. So here we go. These are the 5 categories, and let's start with the first one, functional chest pain. So more specific criteria for functional chest pain, it must include all of the following: retrosternal chest pain or discomfort, absence of an associated esophageal symptom such as heartburn or dysphagia that would suggest that there may be an alternative cause, absence of evidence of gastroesophageal reflux or eosinophilic esophagitis that could be cause of symptoms, and absence of major motor abnormalities. Criteria for failed for 3 months, with onset of symptoms 6 months prior to diagnosis. Looking at the prevalence of non-cardiac chest pain by age and gender, most of the data comes from the non-cardiac chest pain population. There's very little epidemiological work that's been done in functional chest pain. As we know, non-cardiac chest pain does include other causes like gastroesophageal reflux and major motor abnormalities in the esophagus, but just gives us an idea and that the prevalence in amongst all age groups except in the 5th decade is very similar between male and females and ranges anywhere from about 2% to about 4.5% of the general population in this Australian survey. But within the non-cardiac chest pain cohort, it's been demonstrated that about 50-60% have true gastroesophageal reflux, and about 15 to 18% have esophageal dysmotility, and therefore about 30 to 35% will have functional chest pain within that cohort. And in terms of pathophysiology, most of the emphasis is on sensitization of afferent nerves within the gastrointestinal tract, within the esophagus, or sensitization occurring at a more central level within the spinal cord, called central sensitization. And of course, there can be quite a lot of psychological issues like anxiety, stress, somatization, etc. This combination of both peripheral sensitization and central sensitization, peripheral sensitization usually due to some form of injury that will occur or inflammation that will occur to the esophagus. That particular injury or inflammation may have healed, but it has left the nervous system hypersensitized and hence causing greater signals to go up, or misinterpretation of normal signals going up to the brain in presence of anxiety, depression, because of descending modulation from the brain to the spinal nociceptive pathways may be abnormal. So this is termed as the pathophysiology of most of these functional esophageal disorders, and I will come back to that. Psychological state and trait characteristics of patients with functional chest pain have been looked at in various studies, and I think this study by Adam Farmer nicely demonstrates that patients with functional chest pain, if you look at their hospital anxiety and depression scale for anxiety and depression, then looking at their neuroticism scores and extroversion scores and state and trait anxiety, they score differently and higher on most of the parameters in comparison to controls, except that in the extroversion personality trait, they are less likely to be extroverts. So hence psychopathology tends to play an important role here. As part of the ROAM, as John mentioned as well, we've developed algorithms to really try and help people to just work through a particular diagnosis from the time of presentation to the diagnostic evaluation. So there's a patient presenting with chest pain of suspected esophageal origin. So you take a detailed history and physical examination, and if that is suggestive of a non-esophageal etiology, such as musculoskeletal chest pain, you evaluate and treat it accordingly. However, if there is no history, such history suggesting non-esophageal etiology, you need to exclude the risk of cardiac pathology. So you do a cardiac evaluation, and if an abnormality is identified, you treat accordingly. However, if no abnormality is identified and there's no risk of a cardiac etiology, you do a PPI trial. So you can give them a trial of double-dose proton pump inhibitors because you rule out those 50% of patients with non-cardiac chest pain who have reflux, and this is considered to be quite a sensitive way of excluding those patients. And if they still do not respond to that PPI trial, you do an upper GI endoscopy and take a biopsy, and especially to rule out eosinophilic esophagitis. If you identify an abnormality on endoscopy, like reflux esophagitis or eosinophilic esophagitis, you treat them as such. If you do not identify an abnormality, these are the patients that go on to have pH or impedance monitoring of PPIs to really determine whether they could be underlying reflux. And if they have abnormal acid exposure, then they would be classified as non-erosive reflux disease. And if they don't have abnormal acid exposure, they go on to have an esophageal manometry. And there you might have either an esophageal, major esophageal motor disorder, and that acts as an exclusion, and if you don't, then you have functional chest pain. So this is an algorithm that could be useful, especially when you're planning your research studies, but I'm sure this is not something that you'll be looking at day to day in your clinics, although that may well be helpful as well. And when it comes to management of functional chest pain, understanding what the pathophysiology is often helpful in planning treatment. And in patients where there appears to be an element of sensitization of afferent nerves, either peripherally or centrally, then pain modulators like gabapentinoids or tricyclic antidepressants like amitriptyline, SSRIs, SNRIs, they can all be considered in the treatment. And there are small studies, and some of them are placebo-controlled studies, and I'll show you some of the data in the next slide, which seems to show some efficacy for these approaches. But of course, psychological and psychiatric management approaches, such as cognitive behavioral therapy, hypnotherapy, deep breathing, SSRIs, are also important. And quite often, it's not one or the other that is important. Both these factors of psychological factors and peripheral factors may be acting together, which is quite often the case, and therefore both types of approaches would be required. Here is some of the example of the studies that have been done in functional chest pain and with pharmacological agents. As you can see, tricyclic antidepressants have been used, and most of these are randomized control trials. Side effects are common in these, and response rate of over 50% is considered to be clinically relevant. So within the SSRIs, sertraline, paroxetine, citalopram have been used, trazodone, clomipramine, etc. SNRIs like venlafaxine, theophylline, and gabapentin have been used as well. And most of these have shown a degree of efficacy. But these are, again, small studies, and we need much larger phase 2, phase 3 studies with these drugs. So coming to the next category, which is functional heartburn. So the criteria is burning, retrosternal chest discomfort or pain, but there's no symptom relief despite optimum anti-secretory therapy. So you do a BD dose of proton pump inhibitors, and these are the ones that do not respond. And lack of PPI response has a high negative predictive value for the diagnosis of gastroesophageal reflux disease. Absence of evidence of gastroesophageal reflux through pH impedance studies, exclusion of eosinophilic esophagitis and major esophageal motor disorders with HRM. And again, the same criteria must be filled for 3 months, symptom onset at least 6 months before, and frequency of at least twice a week, because that is considered to be really affect the quality of life if you're actually experiencing frequent symptoms like that. In terms of pathophysiology, dilated intercellular spaces have been described in gastroesophageal reflux disease, and indeed in patients with functional heartburn as well, there is evidence that there may be dilated intercellular spaces, less so than true GERD, but much more so than in controls. And how will that affect the perception? Well, noxious, sensitizing luminal substances may access the deeper layers where the nerves are, therefore more likely to produce symptoms. They could induce inflammatory cytokines within these deeper layers without a temporally associated reflux trigger, and they can also activate abnormal central processing of esophageal signals. Could lead to symptom generation, like I described before, if there are a lot of cognitive and other psychological issues and problems with descending inhibitory pathways. Psychological factors are important in functional heartburn as well, and there are several models of acute experimental stress, such as auditory stress and sleep deprivation, which indicate that stress does enhance the perception of esophageal acid in GERD patients. And patients with functional heartburn, compared with patients with reflux-associated symptoms, do show greater general anxiety, somatization, poor social support, etc. Management, we always say in functional disorders provide reassurance, but sometimes that is a bit challenging when you have patients with quite severe symptoms. But at least you let them know that you understand a bit about the condition and there isn't any underlying severe condition like cancer, etc. You avoid repetitive invasive testing. That's not going to help anymore. An escalation of anti-reflux therapy is not going to help with these patients, and avoid anti-reflux surgery in these patients. And repeatedly we get patients who've had anti-reflux surgery and they just continue to get worse. And lack of symptom response to PPIs and a normal acid burden are predictors of poor outcome in terms of anti-reflux surgery. And you treat the hypersensitivity as I've described before, because hypersensitivity again is a common feature. Moving on to the new kid on the block, the reflux hypersensitivity. So this is defined as retrosternal symptoms, including heartburn and chest pain, but normal endoscopy, absence of eosinophilic esophagitis, major motor disorders. But symptoms are triggered by reflex events despite normal acid exposure on pH and impedance monitoring. In other words, these are patients who have physiological reflux and they are symptomatic to that physiological reflux. They can respond to antisecretory therapy, so response to PPIs does not exclude this diagnosis. And again, the criteria must be filled for 3 months and last 6 months and at least twice a week. There can be an overlap between true GERD and reflux hypersensitivity, particularly in treated true GERD, because they may manifest as symptoms to physiological acid burden when monitored on PPI therapy. So you started somebody with true GERD on a PPI, they're still symptomatic, and when you do a physiological assessment, they're actually reacting now to physiological reflux events. 37 to 60% of NERD patients have normal ambulatory pH monitoring studies off medication. So obviously, there is something else going on in these patients, and this is just demonstrated nicely in the study of 329 NERD patients. 36% of them showed symptom reflex correlation in the absence of abnormal reflex parameters, suggesting that they had reflex hypersensitivity. 40% had abnormal acid exposure, so they would be true NERDs, and 24% had normal pH impedance monitoring, suggesting that this would be the functional heartburn category. And an increased number of weekly acidic reflux events and a high rate of proximal reflux discriminated reflux hypersensitivity from functional heartburn. Lesser degrees of overlap exist between reflux hypersensitivity and healthy volunteers, compared with the high overlap between functional heartburn and healthy volunteers. So the reflux hypersensitivity group you can differentiate from healthy volunteers much more easily than you do with functional heartburn. So the true justification of the new category for reflux hypersensitivity in the Rome 3 classification, they included the acid hypersensitive group, i.e. normal esophageal acid exposure but positive symptom association in the NERD population. And there are problems with that. Compared to the NERD patients, patients with acid hypersensitivity respond suboptimally to PPIs. So this is, their response to treatment is different, it is suboptimal. And similarly, PPI response in patients with weakly acidic and non-acid reflux is also poor. So within this category, you have the weakly acidic and non-acid groups as well, and their response is also poor to PPIs. Patients with reflux hypersensitivity show a greater likelihood of esophageal mucosal changes compared with functional heartburn. So they're more likely to have dilated intercellular spaces, basal thickness, papillary elongation. So you can't really put them in the functional heartburn category either. And therefore, the reflux hypersensitive category was introduced to highlight this very specific subgroup. Again, the same pathophysiology as we've mentioned before. Sensitization appears to be, by almost definition, the main pathophysiological feature. And in terms of management, of course, start with reassurance, no ominous diagnosis, but treatment is empiric. Response to anti-secretory therapy may be better than in other functional disorders. It's less than in NERD patients, but better than in functional sort of heartburn. So in that case, you could consider it. Some patients with acid-sensitive esophagus, therefore, may respond to standard double-dose PPIs, and patients with weakly non-acid weak acid and non-acid reflux triggered symptoms are generally refractory to PPIs. Limited evidence suggests that reflux hypersensitivity patients refractory to PPIs can respond to anti-reflux procedures, but this is really one paper, and it just needs to be studied in much more detail. And of course, treating of esophageal hypersensitivity, as previously discussed, would be important. So here's the diagnostic algorithm. The patient presents with heartburn, with normal endoscopy and biopsies. And you have two possibilities: that this patient is already proven to have GERD, and then you take them down a different pathway, and those who have unproven GERD would go down a different pathway. Let's look at the unproven GERD pathway. So on the left-hand side of your screen. So you study them off PPIs with pH and impedance monitoring. If they have normal acid exposure and negative symptom association with reflux events, they would have functional heartburn. If they have normal acid exposure but positive symptom reflux association, these are your reflux hypersensitivity patients, and those with abnormal acid exposure and positive or negative symptom reflux association would be your NERD patients. If you look at the right-hand part of the screen, that these are those with proven GERD. They've previously shown to have esophagitis or responded to PPIs, etc. You do their study on PPIs, and if they have abnormal acid exposure, that's your true GERD. But if they have normal acid exposure, then you look at their symptom association. If it is negative, that's functional heartburn. If it is positive, that's reflux hypersensitivity. Moving on quickly to Globus. The diagnostic criteria suggests persistent, intermittent, non-painful sensation of a lump or foreign body in the throat, no structural lesion identified on physical examination or on endoscopy. This symptom must occur between meals, and there should be absence of dysphagia or dynophagia. Absence of evidence of reflux, absence of a gastric inlet patch in the proximal esophagus, and absence of major esophageal motor disorders. And same as before, 3 months onset, 6 months before. It's a common symptom, reported to be up to 46% of healthy individuals at some time or the other will complain of Globus sensation. Peak onset appears to be the middle age group and prevalent in both sexes, but women are more likely to seek health care. And the condition is quite durable. It lasts for quite some time. Symptoms will typically persist for more than 3 years in 75% of the patients, and 50% have persistent symptoms even after 5 years. So if you've got this feeling of something is stuck in your throat, then that will remain stuck for quite some time, I'm afraid. Why is the criteria changed from before? There's some recent insight about the gastric inlet patch, which is a ectopic gastric mucosa capable of producing acid, and that can lead to a Globus symptom generation, so you have to rule that out. And a concerted effort to support endoscopic evaluation of the oropharynx. You must have an ENT specialist look down your throat to make sure there isn't any other cause for Globus. And similar to other functional disorders, you take out major motor disorders, but you do not take out the borderline motor disorders. Pathophysiology, again, visceral hypersensitivity raised its head. No anatomical abnormalities should be there, like a cricosophageal bar. Upper esophageal sphincter mechanics do not seem relevant, so a spastic upper esophageal sphincter is usually not related to Globus. Pharyngeal swallow mechanism is normal. And esophageal hypersensitivity has been noted, so balloon distension in the esophagus can sometimes reproduce Globus sensation at quite low distending thresholds. And gastroesophageal reflux and distal esophageal motor disorders can induce Globus in their presentations, but they're thought to play really a minimal role in the pathophysiology, but you do need to exclude those. And stress and anxiety are common and may be trigger factors for Globus sensation. Reassure, manage expectations. A lot of these patients are going to have symptoms for a long time. And there are controlled trials of antidepressant behavioral therapy are unavailable, and there's only anecdotal evidence of their utility. So the diagnostic algorithm, patients with a sensation of non-painful lump in the throat, history, physical examination suggests a diagnosis, you evaluate and treat. Esophageal alarm symptoms, you do an upper GI endoscopy. If no, you send for ENT evaluation. If you find an abnormality on endoscopy, you treat it as required. If the ENT evaluation does not indicate any problems, then a PPI trial, and if they respond to PPI trial, fine. If not, they go on to have a manometry. You identify an abnormality with a motor disorder, fine. Otherwise, you do pH and impedance. If you have abnormal acid exposure, you have GERD. If not, you have Globus. Very quickly, functional dysphagia. I'm not going to dwell very much. It's basically food sticking in the esophagus, no structural abnormality, absence of EOE, absence of major esophageal motor disorders. Population survey suggests that 7 to 8% of dysphagia unaccounted by exclusion criteria. Validation of Rome-2 estimated about 0.6% of functional gastrointestinal disease patients complain of frequent dysphagia, and estimated to be at least be the least prevalent functional disorder. And the same, you exclude motor disorders, you exclude EOE, etc. And so abnormal sensory perception is an issue. Minor peristaltic disorders may represent an epiphenomena associated with abnormal sensitivity to the distending stimulus, so they are unlikely to be particularly important. But both peristaltic dysfunction and abnormal visceral sensitivity are potential contributory factors. Treatment, reassurance, simple non-pharmacological measures, eating in upright position, avoid precipitating foods, chew carefully. Short trial of PPIs could be considered. Antidepressants can be tried, the efficacy is unknown. And bougie dilatation has been reported to be of benefit, but it is only 1 or 2 studies, lack of proven efficacy. And there's the algorithm, dysphagic patient, history examination, suggest oropharyngeal dysphagia, evaluate and treat. If not, upper GI endoscopy, biopsy, rule out eosinophilic esophagitis. If no abnormality, reflux symptoms, PPI trial. If they respond to the PPI is fine. If not, manometry, and then you rule out major motor disorders, and the rest may have functional dysphagia. And here's the Rome-4 FED team, functional esophageal disorder team, and I'm sure you recognize most of the people there: Ronnie Fass, John Pandolfino, Prakash Kayavali, Hiro Miva, and Frank Zabib. All of them made a major contribution to the development of these criteria, and thanks to Rome Foundation, and of course sitting in Rome and doing the criteria is not actually so bad. Thank you very much. And all of these people.